right, good morning.
Good morning.
I'll be presenting tarsal tunnel syndrome. Will not be for you long. If you want to, you can find this chart on page 1053 in depth. All right, so the objectives. Students will gain knowledge about tarsal tunnel syndrome. Students will know the cause of tarsal tunnel syndrome. Students will learn about the clinical manifestations. Students will learn vital tests and measures. Students will learn about the differential diagnosis. And students will learn the different components of the rehabilitation process. What is tarsal tunnel syndrome? It is referred to as the posterior tibial nerve neuralgia. Compressive peripheral neuropathy of the posterior tibial nerve. The tarsal tunnel lies below the flexor retinaculum. Oftentimes, the retinaculum gets swollen and it compresses on that nerve. It is often misdiagnosed. It is often seen in runners, hyperpronation, and ages 25 to 50 years. Pathomechanics, flat feet, valgus foot deformity, high arch, ankle sprains or fractures, rapid weight gain, irregular bone growth, tumors, systematic diseases. With flat feet, the outward contact of the heel may cause compression on that nerve. Valgus places the foot in constant pronation. And the systematic diseases are diabetes and rheumatoid arthritis. Clinical manifestations, pain along the inside of the ankle and the sole of the foot. You may have tingling or numbness, often radiates distally. There's a burning sensation, a sharp shooting pain, weakness in the foot, and swelling. Some functional limitations are any of your weight-bearing activities, such as walking, prolonged standing, running, or squatting. Tests and measures we would use, you could see if the patient's symptoms relieve after you put them in elevation. You could do a deep palpation of the medial aspect of the ankle. Sometimes this may not present because it may not be tender to the touch. You can do Tenniel sign. We'll also do the dorsiflexion version test, which is dorsiflexion, eversion, and toe extension. You can make it more sensible by doing hip flexion and knee extension. Do MRI, EMG, and nerve conduction studies. As far as the differential diagnosis, as stated earlier, plantar fasciitis, typically the patient will report that it's worse in the morning. With lumbosacral radiculopathy, this often radiates down, starts in the back. But if you don't have to ask the right questions, you could miss that. Metatarsal stress fractures could have some tingling and pain, sharpness. The Mortons, you would normally see that in toes 3 and 4 and in between the webbing of the toes. Diabetic neuropathy, you would often see tingling in the leg as well, but with tarsal tunnel syndrome, you probably wouldn't see any sensation deficits in the leg. And posterior tibialis tendonitis, this one here, according to Dutton, you would see pain with resisted plantar flexion versus with tarsal tunnel syndrome, you would see toe flexion weakness. Treatment options, the conservative method would be rest the patient off of that foot so much they may be doing too much activity on the foot. Some cryotherapy to kind of control the inflammation. Have them have some supportive inserts so they won't be pronating, over-pronating. Some orthotic shoes, calf strengthening, strengthen the tibialis posterior, so we could do some resisted inversion with the resisted bands and some nerve gliding. Surgical methods where the surgeon would go in and cut the retinaculum and relieve the pressure off of that nerve. I mentioned some of these exercises already, but yes, it's important to educate the patient on their posture. As stated earlier, you may want to look at the hip and see why they may be excessively pronated. It could be anteversion of the hip. You want to do some soft tissue massage and some nerve mobilities. And in the maximum phase, reduce inflammation, patient education, plantar arch taping to encourage that arch to stop overpronating, some calf stretching, soft tissue massage, ankle circles, towel scrunches. Outcome, decreased pain, decreased inflammation, return to activities of daily living, and improved function. Overview, tarsal tunnel syndrome is a condition where the tibial posterior nerve is compressed. It is often referred to as posterior tibial nerve neuralgia. You would typically see this in someone who has hyperpronation. Therapy includes rest, strengthening, and modalities. It is vital to rule in and out other pathologies. All right, sis. Questions?
So when we say foot, valgus foot deformity, are we talking about forefoot, midfoot, or rear foot?
Some refer to rear foot.
Okay. All right. So now make sure that you understand that, because if you see this on the exam, it's going to specify the area of the foot. Because remember, either area can be, when we say valgus foot deformity, which area are we talking about? Are we talking about forefoot valgus, rear foot valgus? Because we have to know the area and know which one is compensated. Okay. So that right there is going to be rear foot. So valgus or rear foot deformity. So I would add rear foot. I would write that down if I were you all. So we say dorsiflexion eversion test. What is dorsiflexion and eversion going to do to posterior tibialis?
Put stress on that nerve.
Okay, so you say we're gonna put stress on that nerve? What is it gonna do to the muscle and tendon? Elongated. So when we talk about stress, stress comes in different forms. Like, so in this case, dorsiflexion eversion, everything is being elongated, whether it's the nerve or the muscle tendon unit. All right.
I have a question for clarification.
Yes,
so,
sir.
I know that if they're hyperpronating, that it could cause tarsal tunnel syndrome. So would you see often the patient actually supinate to take the stress off of the nerve? Would it be the reverse effect?
So they have tarsal tunnel syndrome. They may try if they can. Most likely, if the tarsal tunnel syndrome is occurring due to the biomechanical and neuromusculature inefficiencies, most likely they may not be able to, because they don't have the strength to.
Gotcha.
You see, so they may not have the concentric strength of the posterior tibialis muscle to be able to even try to.
Okay.
Does that make sense what I'm saying? So they have no control over it due to their condition. So what happened is it likely will get worse until they can see some type of intervention and patient education on what they need to be doing. Okay, so they may not know that they may need some shoe inserts. They may not know that they need to go to the good foot store, good feet store to get some shoes with some inserts so they can maybe lift the arch if they have flat feet, things like that. So, yeah. All right. So this is good. So conservative method. Now we've been talking police. So versus rest. So with policing, there's protective, optimal loading, ice, compression, elevation. So now we want them to still move, but pain-free type of movement. Still move, because movement is going to increase oxygenated blood flow to the area to facilitate healing and recovery. Unless rest is like indicated by the physician or the person who if they need surgery or whatever the case, they may recommend absolute rest. So in that case, you do accordingly. So in this one, you indicated that the person could be morphologically, they could be anteverted at the hip. So if they're morphologically anteverted at the hip, that places them to an excessive internal rotation, right? Which could work its way down the biomechanical chain. So now, if that is the case, they could lack eccentric strengthening, eccentric weakness. They could have eccentric weakness of the glute max muscle. So you have to go over and look at the glute max muscle to see the strengthening and functioning of it as well. And that may be something you have to treat. We don't know. We just have to do the assessment. All right. So this is a condition as well. It's good to look at the hip. So as good practitioners, the thorough physical therapy practitioners, who are gonna take the time to find the problem that could be the source of the pain. We know with majority of our foot problems, ankle foot problems, we know we gotta look at the hip, right? Hip and the knee joint. Because we're not gonna be the laser practitioners. We're not gonna be the practitioners who skip the examination process. We're not gonna allow the assembly line concept to dictate how we practice. Because most of y'all are working facilities with the assembly line concept, but you can't allow it to dictate you doing a thorough examination.